Welcome, CyberMDs, to another cardiology lecture for the USMLE Step 1 exam. Please be sure to like, comment, and subscribe so that we can continue to provide free medical education resources for students all around the world. In today's lecture, we're going to discuss the tricuspid valvulopathies. These include tricuspid stenosis, tricuspid regurgitation, and carcinoid syndrome. Let's dive in. First, we'll be discussing tricuspid stenosis. Tricuspid stenosis is a valvulopathy that is the result of the narrowing of the lumen of the actual valve itself. So in other words, that valve becomes stenotic, tricuspid stenosis. It often coexists with other valvular diseases, particularly mitral valve pathology in the setting of rheumatic heart disease. Now, tricuspid stenosis can either be acquired, congenital, or iatrogenic. Of the etiologies of acquired tricuspid stenosis, rheumatic heart disease is the most common, which almost always presents with mitral stenosis along with the tricuspid stenosis if the tricuspid stenosis is present. Rheumatic heart disease is a consequence of acute rheumatic fever, which results in the end in antibodies that damage the heart. This will be discussed in detail in a different lecture, but for the purpose of this lecture, tricuspid stenosis due to rheumatic fever is characterized by a fibrous thickening of the tricuspid valve leaflets and the fusion of the commissures of the valve itself. Other acquired causes include large vegetations or carcinoid syndrome, which we're going to be discussing later. Systemic lupus erythematosus can cause this, as well as anti-phospholipid antibody syndrome. In all of these cases, there is inevitably some sort of growth or compound accumulation on the leaflets themselves, or some sort of fibrosis due to valve damage that causes the valve to become stenotic. In carcinoid syndrome specifically, it results from fibrous plaque deposition due to the vasoactive substance that is released in that syndrome, but we'll discuss all that again later. Whipple disease is an acquired infectious source of tricuspid stenosis. In Whipple disease, I like to think of this as the bacteria itself covering the valve and causing the stenosis. With systemic lupus erythematosus, this can lead to fibrin platelet complexes that form and deposit on the valve, as well as immunoglobulin deposition on the valve as well. It may affect the tricuspid valve, but typically involves the mitral valve. So remember that the tricuspid valve would actually be an atypical presentation for that. In anti-phospholipid antibody syndrome, the immune complexes that form can damage the tricuspid valve, but again, in this pathology of anti-phospholipid antibody syndrome, it's usually going to affect the mitral valve. Just know that it is possible for it to also affect the tricuspid valve as well. Congenital causes include metabolic or enzymatic abnormalities such as Fabry disease. In Fabry disease, the enzyme defect causes a buildup of a compound called GB3 in multiple tissues, including the heart. Iatrogenically, tricuspid stenosis can be caused by permanent pacing or the fusion of an implantable defibrillator, the leads passing through those structures, damaging the valve, causing fibrosis and stenosis. Most of that is going to be beyond the scope of step 1, but I thought I would include it here for completeness sake. It accounts for less than 1% of valvular heart diseases. In the majority of cases, rheumatic heart disease is, again, the underlying cause. Now, what you should take away from this slide, again, is that it accounts for less than 1% of valvular heart diseases, not that it occurs in 1% of the population. Again, the most common cause is going to be rheumatic heart disease. However, all of the underlying etiologies that we've discussed so far could also be considered risk factors. And don't forget that pre-existing cardiac conditions, such as a previous myocardial infarction, can also predispose our patients for these tricuspid valvulopathies. Remember, tricuspid stenosis is a reduction in the size of the lumen between the right atrium and the right ventricle. Tricuspid stenosis primarily results in elevated pressures in the right atrium, leading to right-sided heart congestion. With a smaller lumen to push through, this condition causes an elevated pressure gradient between the right atrium and the right ventricle, even during diastole, which would increase during inspiration and with exercise, as there is that increased right-sided filling, and decreases during expiration as there is a decrease in the negative pressure seen during inspiration. The severity of the tricuspid stenosis dictates whether or not the patient has a acceptable ability to increase their own cardiac output during periods of exercise or other physiologic stress. Remember that there is this physical obstruction to blood flow upstream of the left ventricle, which is where cardiac output is measured. Remember that cardiac output is equal to the stroke volume multiplied by the heart rate. And this condition is going to be reducing that overall stroke volume because you're not getting as much blood into the left side of the heart. Patients with tricuspid stenosis may present with systemic congestion, which could include leg edema, ascites, anasarca, or congestive hepatopathy. The symptoms of reduced cardiac output could include exertional dyspnea, general fatigue, or maybe even syncope. On physical examination, the jugular venous pressure may be elevated and you may see a prominent A wave. And that can be seen as the heart begins to push, or the atria, the right atrium, begins to push against that stenotic valve, causing an increased pressure in the right atrium and then in the areas immediately behind that, which includes the jugular vein. You can also hear potentially a mid-diastolic rumble, sometimes after a distinct opening snap. That would be audible at the fourth intercostal space on the patient's left side. However, that may be hard to discern in this pathology because, again, it often coexists with mitral valve disease. The assessment for tricuspid valve stenosis could include some biochemical tests as well as a chest x-ray, maybe even an EKG. However, echocardiogram, transthoracic ultrasound is going to be ultimately the ideal diagnostic tool, and it's going to allow you to evaluate the valve area as well as pressure gradients and the severity of the stenosis. Management of tricuspid stenosis is going to depend on the underlying cause, the severity, and the patient's overall health. Medical therapy or pharmacotherapy is going to be pretty limited in patients with this valvulopathy, and the treatment is usually going to be focused on addressing the underlying mechanical obstruction. Loop diuretics can be helpful in relieving systemic and hepatic congestion, but again, that's just treating the symptoms rather than treating the underlying etiology itself. Interventional approaches such as percutaneous valvotomy or surgical correction are typically recommended for severe cases or if it progresses and there is severe or significant regurgitation. So, since I brought up regurgitation, let's talk about tricuspid regurgitation. This condition is going to occur when the tricuspid valve does not adequately close, and that's going to lead to a backflow of blood during right ventricular contraction through the tricuspid valve into the right atrium itself. Tricuspid regurgitation can primarily be categorized as either primary or secondary, with secondary tricuspid regurgitation being known as functional tricuspid regurgitation. Primary regurgitation is due to processes that directly affect the tricuspid valve itself, whereas secondary tricuspid regurgitation is going to be tricuspid regurgitation due to some other pathologic process that is forcing maybe right ventricular dilation or tricuspid valve leaflet tethering that is not originally affecting the tricuspid valve itself. Examples of diseases that can cause primary tricuspid regurgitation are going to include endocarditis, rheumatic heart disease, carcinoid syndrome, ischemic heart disease, and trauma. Now, there's a classic association on step 1 with IV drug users and tricuspid regurgitation because the organism known as Staph aureus can enter the bloodstream as IV drug users inject themselves. And the first place in the heart that this organism encounters is the tricuspid valve. And so it infects the body at that location, grows these large vegetations, which ultimately lead to regurgitation due to the damage that they cause and because they prevent the tricuspid valve from closing completely and adequately. Notably, implantable devices that cross the tricuspid valve themselves may also cause acute or chronic tricuspid regurgitation, which makes sense. You have something going through the valve, and so as the valve closes, it can't close all the way because there's something blocking that is actually going straight through the valve itself. Conditions that directly affect the right ventricle or cause an elevation in right ventricular pressure, such as pulmonary hypertension, can also lead to secondary tricuspid regurgitation. Interestingly, during my research for this lecture, the prevalence of this condition I found, especially in adults, is actually pretty significant, with approximately 80% of all adults having at least a trace amount of tricuspid regurgitation. And so with that being said, remember that tricuspid regurgitation as a whole is actually relatively common and is often associated with left-sided heart valve disorders. Again, remember that approximately 80% of people have at least some trace regurgitation. Now, that trace regurgitation, even though this disease is prevalent, might not be clinically significant. And that's important to keep in the back of your mind, that the prevalence is high, but the clinical significance is often slim to none. Common cause for tricuspid regurgitation is going to be a functional tricuspid regurgitation due to right ventricular dilation. This can have multiple etiologies such as left-sided heart failure and pulmonary hypertension. Other etiologies include the aforementioned rheumatic heart disease, endocarditis, and things such as IV drug users, which are all things we've discussed so far. Now, let's dive into the pathophysiology. Tricuspid regurgitation, as we've discussed, is characterized by the backflow of blood from the right ventricle into the right atrium during systole of that right ventricle. With mild or moderately severe tricuspid regurgitation, there are often no major hemodynamic consequences in our patients. However, when tricuspid regurgitation becomes more severe, there can be significant hemodynamic repercussions, which may include right atrium and venous pressure increases, which can lead to signs and symptoms of right-sided heart failure. So, speaking of signs and symptoms of right-sided heart failure, let's move along to the clinical presentation of this disease. Patients may present with those right-sided heart failure symptoms such as peripheral edema, ascites, and hepatomegaly. With severe disease, there may be a sensation of pulsation in the neck, and you may even see some JVD if the disease process is severe enough. However, some patients with severe tricuspid regurgitation can remain asymptomatic for many, many years. Symptoms may also arise from the underlying causes of the regurgitation. For example, you may see other symptoms from rheumatic heart disease or infective endocarditis, and those can help you put together a complete clinical picture for your patient for which you think they have tricuspid stenosis, or you know they have tricuspid stenosis and you don't know the underlying etiology yet. A hallmark finding is a holosystolic murmur that is best heard at the left lower sternal border. It's going to increase with inspiration as you draw more blood in across that valve, and that's going to be a phenomenon that's known as Carvallo's sign. Again, in terms of diagnosis, echo or transthoracic ultrasound is going to be the primary diagnostic tool for tricuspid regurgitation. You may see some chest x-rays or some EKGs or biochemical tests get ordered, but in the end, ultrasound or transthoracic echo, all of those things are going to be the primary diagnostic tool that is used for patients who we have a suspicion for tricuspid regurgitation. Finally, the management of tricuspid regurgitation is going to aim to treat the symptoms as well as the underlying cause. If the case is really severe, there may be surgical intervention that is required. Additionally, lifestyle modifications and medications could also be prescribed to manage the symptoms of heart failure that come along with tricuspid regurgitation. These medications may include ACE inhibitors, beta blockers, or diuretics if the etiology itself is heart failure. Let's talk about carcinoid syndrome, which is derived from a carcinoid tumor, which is a type of neuroendocrine tumor. These often originate in the digestive tract, and the lungs or other rare primary sites can include the kidneys or the ovaries. These are going to cause the secretion of hormones, most often serotonin. Syndrome is often the result of disseminated disease from a neuroendocrine tumor, specifically hepatic metastases. These hepatic metastases lead to secretion of the tumor products into systemic circulation, causing the carcinoid syndrome. This is because if the tumor is metastasized all the way to the liver, the products from that tumor are no longer metabolized by the liver, and therefore they can move on into circulation and affect other parts of the body. These neuroendocrine tumors are relatively rare, and only around 10% of neuroendocrine tumors ever progress to carcinoid syndrome. The incidence is approximately 5 in 100,000, but that incidence is on the rise. The incidence is greater in males than in females and is slightly higher in the African American population than in the Caucasian population. Patients are typically diagnosed between the ages of 55 and 60. The common cause of carcinoid syndrome is, again, the presence of liver metastases of a carcinoid tumor, typically in patients with gastrointestinal neuroendocrine tumors. Remember that such metastases result in the secretion of those tumor products into systemic circulation, causing this syndrome. In addition, risk factors may include primary tumors located in the midgut, lung, distal colon, or the rectum. The pathophysiology of carcinoid syndrome actually involves alterations in tryptophan metabolism. Normally, only about 1% of dietary tryptophan is actually going to be converted into serotonin, but in carcinoid syndrome, this can actually increase to like 70% or even more, 80, 90% perhaps. So these neuroendocrine tumors are secreting serotonin, but they're going to be doing that by taking more tryptophan from your diet and altering more of that into serotonin. These excessive serotonin levels can stimulate fibroblast growth and fibrogenesis, which leads to the cardiac valvular fibrosis. Serotonin produced by carcinoid tumors again stimulates intestinal secretion and motility while inhibiting absorption, which can lead to diarrhea. Serotonin can also lead to a niacin deficiency, which is going to be characterized by decreased protein synthesis and hypoalbuminemia. Now, the easiest way to remember the clinical manifestations of carcinoid syndrome is going to be with a mnemonic BFDR, which stands for bronchospasm, flushing, diarrhea, and right-sided heart disease. The bronchospasm produced in these patients is due to histamine release, while the flushing can occur suddenly, but will primarily involve the face, the neck, and maybe the upper torso. The bronchospasm can lead to wheezing on physical exam, so look for wheezing on your clinical presentation. And then the flushing could be very quick, it could come and go very fast, or it can last up to 30 minutes. Now that flushing is going to be caused by the tumor secreting small amounts of histamine and bradykinins, which cause vasodilation, which is the underlying etiology for that flushing. Now those things, those histamines and bradykinins, those can actually be increased in the amount that they're secreted in if patients eat or ingest foods that have high amounts of something called tyramine, which is a monoamine. The reason for this is that it will indirectly stimulate the release of catecholamines. That in turn subsequently causes the tumor to release more compounds, more serotonin, more histamine, more bradykinins. So things to avoid for these patients can include aged cheese, alcohol products such as wine or beer, vinegar, smoked and salted fish and other meats, yeast, and soybean products such as soy sauce or tofu. Two of the most common manifestations of carcinoid syndrome, so two of the most common clinical presenting chief complaints, are actually going to be the flushing and the diarrhea. The diarrhea is often watery and can be accompanied by abdominal cramping. The diarrhea is due to the presence of, again, excess amounts of serotonin secreted by the tumor, which stimulates the secretion of colonic mucus. It's also going to increase the peristalsis in our GI tract. And finally, it's going to inhibit certain amounts of absorption in the GI tract. All of that combined is going to lead to the watery diarrhea seen in patients with carcinoid syndrome. Lastly, remember that for this lecture in particular, carcinoid syndrome is also a form of valvular heart disease, specifically a tricuspid valvulopathy. As that serotonin increases, it's going to release other vasoactive substances, and all of these things are going to cause fibrous plaque formation and deposition on the endocardium, especially the tricuspid valve, which can lead to tricuspid valve dysfunction, typically in the form of tricuspid regurgitation. It's also extremely high yield to remember that the reason that there is no progression from right-sided heart disease to include left-sided heart disease is that serotonin secreted by the tumor is metabolized into a substance known as 5-HIAA, again that's 5-HIAA, as it passes into the lungs and encounters type 2 pneumocytes. Again, type 2 pneumocytes are going to convert serotonin in the lungs into 5-HIAA. As diagnostics go for patients with carcinoid syndrome, echocardiography, blood tests for chromogranin A, and urine 5-HIAA levels are the most important diagnostic criteria for carcinoid syndrome. The measurement of 24-hour urinary excretion of that 5-HIAA compound, which again is the end product of serotonin metabolism, is the preferred initial diagnostic test for carcinoid syndrome. Non-hormonal peptide biomarkers such as chromogranin A, again, can be useful in assessing disease progression, response to therapy, or in some cases, recurrence after a surgical resection. In addition to these, serum levels of gastrin and vasointestinal polypeptide, or VIP, can aid in the differential diagnosis of patients with carcinoid syndrome, which means that given all of this information on an exam, it can help you to rule in or rule out carcinoid syndrome as a potential etiology of the patient's pathology. Management of carcinoid syndrome revolves around, again, treating symptoms and, when possible, treating the underlying tumor itself. The treatment may involve somatostatin analogs, such as octreotide on the slide here, which can help to control the hormone hypersecretion of serotonin and those other products, as well as targeted therapies such as cytotoxic chemotherapy for tumor control, and then in some cases, when possible, surgical resection of that primary tumor may be beneficial and may be curative if it's caught early enough. The management of carcinoid crisis includes avoiding triggers such as those tyramine-containing foods and beverages that we discussed earlier, as well as some forms of anesthesia and forms of tumor manipulation as well, because as we actually physically manipulate these tumors and press on them, we can actually cause increased release of serotonin, of bradykinin, and of histamine. In conclusion, the tricuspid valvulopathies include tricuspid stenosis, tricuspid regurgitation, and carcinoid syndrome, all of which have multiple etiologies and a variety of clinical presentations that can be compared and contrasted on an exam. Thanks for tuning in, and please tell your friends about our content if you find it helpful in any way at all, and remember to like, comment, and subscribe so that we can continue to provide free medical education resources for students all around the world. Thanks, you guys.